Now the floor for questions. Let me explain. I want please one question per person if possible. If we got time, we'll do a second round. You identify yourself, and then we'll try to answer as quick as possible. So we'll start here, then we'll move to the next question.
Hi, excuse me, Neil Osterwile with Oncology Practice. A question for Dr. Hussain, please. What's the frequency of, or do you know an estimate of the frequency of these mutations that you see in the patients with the metastatic disease?
It's actually an excellent question. Just to summarize it, the frequency of the genetic alterations that we see. So basically, it's somewhere around 27% or so. And I would refer you actually to the poster discussion that was presented yesterday. The details of all the genomics in there, it's somewhere around that region. This is also driven by where do you get the tissue from. So the figures I'm quoting you in the high 20% is coming from the primary tissue biopsies. In the metastatic tissue, based on the work that we've done, looks like around 31%, so slightly higher rate. I think from my practice, we used to biopsy patients with metastatic disease. Sometimes it's not easy to biopsy the bone and acquire adequate tissue. And so the finding from this trial, I think, is very encouraging in that what I would recommend for physicians is to see if there's a primary tissue available. Sometimes the primary tissue could be from a metastatic site where the patient got a biopsy from a lymph node, for example. And then if there is nothing there, then I think putting the patients to a fresh biopsy would not be a bad idea.
We've got a question in row 2. Yep, the microphone is coming.
Hi, Alice Goodman with the ASCO Post. So in order to molecularly test men with prostate cancer, that's not widespread in the United States. It's done at academic centers. So where do we take this? This is a very important study, and I'm happy to see it.
Thank you. Excellent question. I think that, like anything else, in other cancers, physicians who are seeing, let's say, women with breast and with ovarian cancer or with lung cancer, genomic testing is routine because of certain standard of care treatments. I think that gradually, and this is where I think we need to begin to educate the community and share information with them regarding the merits of testing for patients with prostate cancer. There is the issue, of course, that we have not touched on, and this is really not part of the topic, is the issue of germline and the implication for family members and so on. And the NCCN has actually adjusted their guidelines regarding that, so I would refer you to that. But it's a process of learning, and I think this is just opening up the door for us right now.
We have a question there, and then we'll have a question here, and then you will be third.
Shriyananda from MedWire News. Sorry, got a cold. Question for Dr. Grande, please. Have you looked at any other biomarkers besides PD-L1?
We are working on that. This is the first communication, the first report of the data. We only analyze at this time point the PD-L1 expression, but we are working in two aspects of the biology. We are working on the molecular signatures of the bladder cancer tumors, and we are working also in the molecular signature for immunotherapy, predictive for activity for immunotherapy, but this is too early to do that. We are working on it. Thank you.
We've got a question here, and then there.
Thank you, Jacob Please from Vantage in London. I have a question for Dr. Abu Alfa and also Dr. Lamarca. There was a study at ESMO we saw in a different mutation in cholangio, that was FGFR2, where we saw median overall survival of over 20 months. Now, in this study, you saw 10.8 months. Can you comment on that? I mean, is there anything about the ADH1 mutation that gives patients a particularly poor prognosis, for instance? Thank you.
Yeah,
Sure, thank you. Go ahead.
You go first. You go first.
So number one is it will be unfair to compare the genetic changes. The FGFR2 that you're referring to, which I was a senior author on, is actually a fusion protein. And here we're talking about the mutation for the IDH1. These are mutually exclusive genetic alterations, i.e. the disease can have this or that, but they don't really join together or happen at the same time. A very important point also from the practical point, this is a phase 3 clinical trial, while what we showed at the oral discussion on Friday was actually a phase 2 study, and understandably it will be unfair to compare the survival of a phase 3 to a phase 2, regardless of the genetic target that we're talking about. So.
what I will add to that probably is that there is some evidence, but it's coming from retrospective studies of the fact that the tumors with FGFR2 fusion may have a better prognosis. We don't think, or we don't know yet, whether the IDH has any impact on prognosis as yet. So I think that could also, in addition to the fact that one is a phase 2 and one is a phase 3, and I completely agree with what Dr. Abu Alfa has said, in addition to that, we need to take into account that maybe that prolonger PFS or overall survival is because of a better natural history as well.
We got a question there, and then next person will be here.
Also to Dr. Abu Alfa, I'm with the ASCO Post. Do you see the same toxicities as you see in AML with the IDH inhibitors? Or what were they specifically in your study?
So the toxicities that we have seen on this study in regard to all grades were driven by 3, mainly diarrhea, fatigue, and nausea. In regard to the grade 3 that occurred, were mainly driven by high bilirubin, high AST, anemia, and ascites. I would say that all in all, the numbers were limited in regard to how much of this occurred. And understandably, from personal experience with the drug, it's rather well tolerated.
I think we had a question here. Are you still interested? Yep. Then we'll move to, we got 2 questions at the back of the room.
Lynn Peterson with Trends in Medicine. Dr. Grande, I'm just a little concerned with the presentation when you don't make your endpoints and yet put as positive a spin on this. It's not normally how we do it.
No, thank you. We have 2 co-primary endpoints. So at that time, we are presenting the final results for the progression-free survival, which is met. And we need a longer follow-up to have the enough events to show an improvement in overall survival. At this time point, after 11.8 months of follow-up, we don't have the needed events to get the median OS for that. The median OS, the planified median OS, the estimated median OS that we have is 13.4 months for the chemotherapy arm versus 16 months with the combination arm. Hazard ratio is consistent with the hazard ratio we have for PFS, and we are expecting that with a longer follow-up, maybe we will have this improvement in overall survival, a statistical improvement in overall survival. Not met yet.
Got 1 question at the back and another question later at the corner.
This question is also for Dr. Grande. Charles Bankhead, MedPage Today. I noticed that in the survival analysis by PD-L1 expression, that the chemotherapy arm, the survival improved by about 5 months as well. Is this a common observation in studies comparing these drugs, or was this an anomaly? What can you tell me about that?
No, this is for the first time we have this kind of results in a prospective randomized fashion. I think this is clinically relevant, but this is an opinion. This is what we found. The good thing from this trial is that in the chemotherapy arm, there were included cisplatin eligible and cisplatin ineligible patients, which is the first phase 3 trial combining these 2 different populations in only one trial. We are learning a lot from this trial. As I said, this is the largest ever trial reported in this setting, and only those patients eligible for cisplatin were included so far, or only ineligible for cisplatin patients were included in a randomized fashion phase 3. This is for the first time that we are combining these 2 populations, and according to the expression of PD-L1, it seems that those patients with this overexpression may benefit not from the chemotherapy, but from receiving a PD-L1 inhibitor as a single agent. Other subgroup analysis, these patients are benefiting more from the combination than from the monotherapy with PD-L1, are ongoing, and hopefully we will see that next year.
Got a question in the corner.
Hi, Christy Risk from Precision Ecology News. This is a question for Dr. Hussein. Did the patients in cohort B respond as well as the patients in cohort A to olaparib? And if not, are there targeted treatments that those patients could benefit from that are keyed to the genes that they had?
So this is, again, an excellent question. There is a response. I don't have the specific data to provide at this moment. The response duration was, relatively speaking, shorter which I think highlights the point, is that the earlier we move some of these treatments, the better the return on investment, so to speak, will likely be from treatment. And this is really not surprising in the context of all cancers, but in prostate cancer. When we give, let's say, abiraterone frontline versus second line, it gives you a different outcome. But there was a response. And what I showed you in terms of the overall trends on the overall survival, this is actually despite a crossover that occurred. So the signals are there, but obviously not mature yet.
We have one question here, and then we'll go to the next one there.
Hi, Amy Brown from Vantage. It's kind of a follow-on question from that, actually. Presumably, the justifies moving PARPs into earlier lines of treatment in prostate. Are there any trials ongoing in earlier settings that you're watching out for?
So there are several different trials that are going on in the frontline setting, evaluating, again, the role of PARP. There are also phase 2 type trials, examples, some work we are doing in the frontline in pre-selected populations, trying to look at whether a PARP inhibitor is as good as an AR-targeted agent and whether the combination is better. So there's lots of questions that are going on. One of the phase 3s that is occurring right now is in frontline in combination with abiraterone, and not in a pre-selected population, because there is biology that would suggest co-targeting the androgen receptor and PARP may actually have a synergistic effect. So lots of questions, and I think more trials will definitely be happening.
We got a question there.
Linda Williams from Medwar News. I had a similar question for Dr. Abu Alpha. At the moment, you're for advanced metastatic disease, would you consider, is this testing and drug something that you could use in an earlier line or earlier stage of disease?
So understandably, at this point, the data that we presented applies for patients who have advanced disease, including metastatic disease. Probably about more than 90% of the patients on the study had metastatic disease, other had locally advanced disease. At this point, moving forward, of course, opportunities will be looked at and considered in different directions. Understandably, for the adjuvant therapy, we have to put into perspective the applicability of the genetic mutation and what will be the action at that early phase of the disease. But by all means, all of those are being studied and considered at this point.
There is couple of questions here, sir.
Hi, Ed Sussman with MedPage Today. Dr. Lamarca, in your commentary on Dr. Abu Alpha's study, I'm just wondering, we have about a 1-month improvement in progression-free survival here. Is this going to do we necessarily have to have a cost-effectiveness study to determine whether the regulators are going to approve this, because we know all these drugs are very expensive?
That's a very important question as well. So obviously, these drugs will need to go through all type of regulatory approval before they can go into clinical practice. I would like to comment, when we are in cholangiocarcinoma, because it's a very aggressive disease, it has happened in the past as well when we presented the second-line chemotherapy data earlier this year in ASCO. Also, we saw that the median is not really showing a huge difference. That's why when you are looking at the Kaplan-Meier curve, you have to look beyond the median. I agree with you that the difference in the median is not, it may seem short, but if you look at the Kaplan-Meier, I think there is a benefit for some patients. And the fact that in one group, all the patients were having progressive disease at 6 months and at 12 months, and the fact that with your drug, you are able to have 30% of those patients free of progression at 6 months is clinically meaningful. And I think it will need to be taken into account when the economic evaluation is being performed.
If I may ask here or add there, I totally agree with what Dr. Lamarca mentioned. Very important point that, remember, we're using a certain language that we know, but we're using it for something that's rather novel to us. The progression-free survival is only measured when you have a CAT scan. And as you notice from the curve that I presented, the first CAT scan happened at about 6 weeks, which is 1 month and a half. And this is where the separation of the curves did occur. So for that reason, I would say, and I totally agree with Dr. Lamarca, the focus should not be necessarily on the median, even though it was positive, but more on how the spread of the curve and the continuation of the spread, that as we saw, it really carried on all the way 22% at 12 months.
Okay, well, I'm afraid we've run out of time, so I'd like to thank all the speakers and